If you're in business, you probably have a website, but can your site handle your growth? How many visitors before your site slows down or crashes? What about storage and data security? From web hosting to virtual servers, Pair Networks provides the online infrastructure you need to start, grow, and flourish. When it comes to security and updates, don't worry, we've got you covered. Our 24/7 US-based customer support is the best in the industry. No frustrating chatbots or sitting on hold for hours. Check out pair.com today to learn more. That's PAIR.com.
Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hey everyone, welcome. I'm Susan Kaufman. I'm here for Attitude Magazine, and you're listening to Attitude's ADHD Expert Broadcasts. One of the most difficult part of living with ADHD can be the emotional intensity, the managing emotions, and living with the ups and downs of the emotional life with ADHD. So today we're really happy to welcome back Dr. William Dodson, who will be talking about the extreme sensitivity to criticism and judgment that seems to exist in people diagnosed with this disorder. In fact, as Dr. Dodson will discuss, emotional dysregulation is increasingly considered a primary feature of ADHD, pretty much at all stages of the life cycle. And it may even be unique to people with ADHD in its intensity. So he'll be talking about the treatments for emotional dysregulation, including behavior therapy and medication, both. Dr. Dodson is a board-certified adult psychiatrist who's been specializing in adults with ADHD for the last 25 years. He was named a Life Fellow of the American Psychiatric Association in recognition of his clinical contributions to the field. And he is also the recipient of the Maxwell Schleifer Award for Distinguished Services to People with Disabilities. He has a consultative practice in Greenwood Village, Colorado. And I'm very proud to say, a member of Attitude's ADHD Specialist Panel. So, Dr. Dodson, thank you, as always, so much for joining us today and for all that you've done to make ADHD understood out there in among the adults who are suffering from it. We very much appreciate your time.
Glad to be here.
I would also like to thank the sponsor of today's webinar and to give you their message, which is, and the sponsor is Omega Bright. Omega Bright 710/MD is a proprietary high-concentrate omega-3 formulation. It was developed by Dr. Carol Locke while she was on the faculty at Harvard Medical School. It has been clinically demonstrated to reduce anxiety by 20% in medical students in an NIH-funded double-blind, placebo-controlled clinical trial, and to reduce inflammatory cytokines by 14%. So it's available exclusively on the Omega Bright website, omegabright.com. And thank you, Omega Bright. I hope you'll all take advantage of that link. Before I turn it over to Dr. Dodson, I just want to ask our listeners to share what your interest is in this topic in a brief poll. We're going to just ask you, what is your primary interest in today's webinar? Is it emotional dysregulation in general, or is it more specifically rejection-sensitive dysphoria, the feeling that of taking judgments with a great deal of intensity? While you're completing the poll, let me just remind you, as always with our broadcast, Dr. Dodson will present his slides, and then he'll take as many questions as time permits. Please go ahead and post your questions at any time as they occur to you. You may download Dr. Dodson's slides now if you'd like to, or you can download them after the webinar when the replay is available. And let me also remind you that webinars are very bandwidth intensive. These are online, conducted online through your internet provider. So for best listening experience, you should close any open browser sessions that may be running in the background. So with that, let's see what we have here for a slide presentation. Do we have an answer to the slides? Yes, so kind of even both. Okay, primary interest in both areas. All right, great. Well, send results to audience. I guess I'll click that. Thank you, everyone, again for being here. And Dr. Dodson, let me turn it over to you.
Sure. As Susan said, there is suddenly a very large interest in the whole subject of emotional dysregulation in ADHD. That has been driven, oddly enough, by the Food and Drug Administration, which has just opened up several pathways that drug companies can study emotional dysregulation and whether or not their medications can get an FDA indication for emotional dysregulation. So it's sort of follow the money. Up until then, there was not a great deal of interest for ADHD emotional dysregulation. We have to understand that the ADHD diagnostic criteria were not made for people like you and me, either practitioners or people who have ADHD or their families. They were designed for and made by people who do research. And pretty much that's it. People who do research have to have criteria that they can physically see and count. Little Johnny was up and out of his chair 3 times in the last hour, and you can write a 3 on your clipboard. Things which are invisible, not always there, hard to count, or even hidden by the patient, don't lend themselves to research very easily and so tend to be ignored. And so consequently, this was one of the main reasons why emotional dysregulation, until there was some other motive provided, was pretty much ignored and disregarded. Consequently, ADHD right now, if you look at the 18 diagnostic criteria, are almost entirely behavioral criteria. What is the person doing? Not how is the person thinking? What is the patient feeling? How are they controlling their emotions? How are they sleeping? Things that are all very, very important to the person who has ADHD, but which is essentially ignored by the diagnostic criteria. Why should you care? Who really cares about this? Well, the definition of what ADHD is and isn't defines who and what will be studied. It defines who will actually get into a study and what questions will be asked. It defines who will be diagnosed with ADHD and who will not. One of the most common problems I get is with a secondary referral to me is that somebody clearly has ADHD, but they're not pinging off the walls. They can sit and do their work, especially when they get into a hyperfocus. And so they're told they couldn't possibly have ADHD when really they just have the inattentive subtype, and they're not being driven by their behavior, their overt behavior. Therefore, it defines who will get treatment, who will get insurance coverage for that treatment, and who will get accommodations in the school when they're young and at the workplace when they're older. Consequently, we should also care because the other major components of ADHD get ignored. And these are the ones that, if you really stand back and look at it, cause the greatest amount of impairment, greatest amount of embarrassment, greatest amount of just problems in general. We're talking about cognition and thinking, that people with ADHD fundamentally think in a different way than do neurotypical people. They are able to engage with the tasks of their lives in a totally different way. Their ability to control their emotions and their behavior, control their emotional responses, tremendously affect their self-esteem and their self-definition. Who am I? What am I worth? What am I valued? Why am I valued in a certain way? What do other people think of me? It affects tremendously the nature and healthiness of relationships. How do you respond emotionally to the people in your realm makes a great deal of difference about the healthiness and gratification you get from your relationships. Being highly dysregulated in terms of your energy and emotions also affects deeply how well you sleep, how easy it is to fall asleep and awake refreshed. And of course, it affects emotional dysregulation And this is probably, when you look at it in the long term, and especially with adults, probably the most impairing part of the ADHD syndrome. The vast majority of people with ADHD have found ways around their academic and work performance, but they haven't found their way around their emotional reactions to the people and events of their lives. At all points in the life cycle, child, adolescent, adult, and elderly, people who have ADHD nervous systems lead intense, passionate lives. Their highs are higher, their lows are lower. All of their emotions are much more intense. And that it really is what we're talking about is not really the quality of the emotions. People who have ADHD have the same types of emotions for the same reasons that everybody else does. What we're talking here in terms of dysregulation is two things. One, the expression of emotions, being able to choose whether or not you let an emotion out. And then when you do decide to express it, how intensely that emotion is experienced and expressed by you as a unique individual. Consequently, just about everybody with ADHD, but especially little children, are always at some sort of risk of being overwhelmed by their own emotions from within themselves. This is something that needs to be really emphasized, is that a lot of people with ADHD grow up not being able to trust themselves. So why is this happening, especially to people with ADHD? I think that just about everybody now would agree that ADHD is primarily a problem of insufficient inhibition, being able to slow down and keep things from happening. If you look at the mass of the human brain, 85% of all the nerves in your brain and out in your nervous system are inhibitory in function. We happen to be aware of the other 15% because we can see what happens when those nerves are used. They create movement, they create emotions, they create our experience and memory. But we have to remember they are a minority of the actual mass of the human brain. Most of what happens inside the brain occurs outside of awareness. What happens is the brain starts something, it gets it moving, and then uses inhibition to guide that toward the destination where it wants. It's like shooting off a rocket. Shooting it off is the easy part. Guiding it to where you want it to go is the hard part. When you look at where stimulant class medications work, they work solely in the deep areas of the brain, down in the basal ganglion, especially in an area called the corpus striatum, which is just Latin for a striped body. That's how it looks when you look at it, is that it's got many, many very fine stripes in it. This area, the corpus striatum, is almost entirely inhibitory in function. And what it does is it inhibits neurological input and output to just the one piece of information or one action that happens to be most important at that time. Everything else gets handled, but it gets handled out of awareness. Probably the easiest place to see this in action is when we're driving a car. Driving a car is the most difficult thing that the average human being ever has to learn how to do. And it's a very difficult process if anybody has ever had an adolescent learning to drive. But once we learn how to drive a car, we do it largely outside of our own conscious awareness. We can drive along, talk to the person on the seat next to us, think about what we're going to have for dinner, sing along to the radio, and not really pay conscious attention to what's going on around us. But if suddenly something is out in front of the car, even before our conscious brain can process what that thing is, our corpus striatum has already handled it. Slam on the brakes, swerve to miss it, start to question that person's parentage in the twinkling of an eye. The corpus striatum has been scanning everything, handling everything. So basically what ADHD is that a relative lack of inhibition that should be there. Inattention, which is a cardinal feature of ADHD, is the relative lack of the inhibition of other inputs, distractions. When we look at physiologically what's happening, we don't actually pay attention to one thing. Neurologically, we suppress every other thing we might engage with except the one thing that we want. It is maximally inefficient in that way. Impulsivity is a relative lack of inhibition of the expression of actions and emotions before you can think about them and make decisions about that expression. Hyperactivity is the relative lack of inhibition of physical and mental activity. When the physical activity of the hyperactive little boy who's pinging off the wall goes away in adolescence, they're still very much mentally active in their own brains. So what? The so what for most of us is that when this area of the brain is not working as it should, people cannot regulate the experience and expression of their emotions. Emotions are experienced as completely unmodified and unscreened. The word that most people use is that they are raw. They come out without any modification at all. They go in without any modification at all. And people can see this in hyperacusis, where somebody chewing or the conversation across the restaurant comes in loud and clear because it can't be screened out. All of this is tremendously overwhelming. We get overwhelmed by entirely too much input and the impulse to have entirely too much output. It's exhausting. And when it does get inappropriately expressed, it's embarrassing. So consequently, people with ADHD must always be vigilant of themselves. When we look at the traditional therapies that have been used or tried to be used with ADHD, they have had very, very poor track records. They're largely ineffective in helping people control the expression of what they think and feel. The reason for this is that people with ADHD don't see their own emotions, their own actions coming. They find out about their emotions and actions the same way everybody else does. It's already out there. Before they even know that it's coming. Consequently, they don't have the time and the warning to use the techniques and new skills that they may have learned in behavior modification therapy or in cognitive therapy. They learned them perfectly well, but the cat's out of the bag before they can make use of them. Right now, as we sit here today, medications are the only thing we have to offer that have a proven track record because they're there all the time. We have two basic groups. We have the stimulant class medications, which are amphetamine, methylphenidate, etc., which help directly with inhibition. They help slow things down. They help inhibit both input that would distract us and output. It gives you the same 2 seconds that everybody else has to see an emotion or an action coming up, to play it out in your mind. If this happens, then this will happen, then that'll happen. Oh, I don't want that to happen. I'll redirect it. The alpha agonists, of which we have two, guanfacine and clonidine, inhibit the energy driving the speed and intensity of response. Interesting enough, when we look at just plain effectiveness, when we measure how effective is this treatment, the alpha agonists are significantly more effective than are the stimulants. Usually that's kind of a false choice because most people end up taking both classes of medication. A very special type, I think, of emotional dysregulation is, again, a terrible technical term, what's called rejection-sensitive dysphoria. We actually don't know what it is. It's much too early to tell. But it does seem to be a thing with which many people with ADHD identify. There was a brief article from Attitude that got posted on Reddit, on their subreddit on ADHD. That particular posting got twice as many responses in less than a month than any other posting that had ever been put on that subreddit. It really touched a lot of people in a strong way. In my own checklist, when I'm asking about rejection-sensitive dysphoria, the question I have is, for your entire life, in other words, going all the way back into childhood, have you always been much more sensitive than other people you know to rejection, teasing, criticism, or your own perception that you've failed or fallen short? This is directly from a psychiatric textbook, an old one, and it's the definition of a technical term for psychiatrists called rejection-sensitive dysphoria. It's important to note this is all a matter of degree. No one likes being rejected or criticized. Everybody hates it when we fail, we fall short, especially in front of other people. Rejection-sensitive dysphoria is much more intense, and is much more than this universal discomfort. When they were originally doing the research on this particular idea back 45 years ago, they wanted to get that intensity right up there in the name, and so they chose the word dysphoria, which unfortunately happens to be Greek, but it means unbearable, because that was the description they were getting from people over and over and over again. For, again, reasons unknown, people with rejection sensitivity have trouble describing what the intense emotion is all about. They can describe its intensity. It's awful, it's terrible, it's catastrophic, but not the quality of the mood. And so over and over again, these research subjects would finally just tell the researcher, look, man, back off. I can't find words to tell you what this awful feeling feels like, but I want you to know I can hardly stand it. And so that's where the word dysphoria came from. There's a researcher at Harvard who decided to put it into Greek, but that unbearable quality is very much a part of what's going on, a part of the experience of rejection-sensitive dysphoria. It's extremely common in people with ADHD. My guess is that about 95% of my patients report it as a significant impairment, and about a third of my patients say that that is by far the most impairing part of their ADHD. For the majority of people and most of occurrences, it is not that particularly disruptive. But when it hits, it turns your life upside down. So how is rejection sensitivity experienced? There's no warning. Hits out of the blue. There's no way to protect yourself from it. It happens all at once. It goes from 0 to 100% instantaneously. It is commonly experienced as being physically painful, as if someone just punched you in the chest or punched you in the stomach. There's an aching in the core of your being. Once it gets started, it seems to be largely uncontrollable until it's run its course, whatever it is. The quality of the mood is indescribable. Most people struggle to find any words at all to describe this feeling, even though it's massively intense. The duration can be a few minutes to several months in duration. It's a very, very potent experience and can make it very difficult to risk ever being rejected or criticized again. If this very intense emotional reaction is internalized, it looks for all the world like an instantaneous major depression, complete with suicidal thinking. And so a lot of times people do get a diagnosis of major depression because the clinician they're working with fails to pick up the triggered instantaneous nature of the onset of that depressive looking syndrome. If it's externalized, it presents as a rage that is directed at the person or situation that wounded them so terribly. In fact, being wounded is a very common description. This sort of sudden triggered change with an intense emotional response not uncommonly leads to a misdiagnosis of borderline character organization. So if you can't see it coming, you can't do anything once it's happened, how do people try and protect themselves from episodes of rejection sensitivity happening in the first place? Some people use perfectionism. They try to be above reproach. They feel driven to be the very best at everything they do. These are the penultimate overachievers. It works, but it's also an absolutely terrible, driven way in which to live. By far the most common response is that people become people pleasers. They are constantly scanning everybody around them and trying to figure out what that person wants or would approve of, and that's what they give them. So much so that it is to the exclusion of what they want for their own lives. These are people who take care of others, please others, to the exclusion of any sort of gratification in their own lives. Another very common way that people try to deal with this is that they give up trying anything new, giving up anything in which they might fail or be embarrassed. I have hundreds of patients who have never been able to apply for a job or ask someone of the opposite sex out for a date. Just the imagination of being told no is so frightening, so devastating that they just say, no, I'm not going there. I'll sit this one out. One of the most effective ways of dealing with this are the alpha agonist medications. And when they work, they can be almost completely effective. Alpha agonist, again, is a tongue-twisting name, but it's not as tongue-twisting as the full name, which is alpha-2 selective adrenergic agonists. So you can see why we sort of shorten it a bit. They were originally blood pressure medications that came on the market in the early 1980s. They worked very poorly. When they did work, at most they lowered blood pressure about 10%, which was measurable, but it still required other things that needed to be done in order to get most people's blood pressure down into a therapeutic range. We have two of them, guanfacine, which was marketed both as immediate release and extended release under the name of Intuniv, and clonidine, which was marketed under the trade name of Capvay, both as an immediate release product and as a delayed release product. They have been used as a treatment of the hyperactive component of ADHD for more than 30 years. So these are not new medications for the field of ADHD. They're very much the treatment of choice for the hyperactive, disruptive, and obnoxious little boy that is what most people have in their minds when they consider the notion of what does a person with ADHD look like. The exact mechanism of action of these medications, both in ADHD and especially in rejection sensitivity, is highly unclear. We really don't know. I have a couple of ideas, but they are very definitely theoretical. But the only thing that we know for sure is that the stimulants don't work by stimulating anything, and that the alpha agonists don't work by being alpha agonists. How they do work is completely unknown. We have two medications. They seem to work equally well. So there's nothing that would lead you to choose one over the other. The problem is that the robust response that we're looking for that really changes people's lives is disappointingly low at about 30% to either molecule. Luckily, that 30% is a different 30% of people. So that 30% of people get a good response to guanfacine, but it's largely a different 30% that get a response to clonidine. So if the first medication tried does not work, it makes good clinical sense that that one should be stopped and the other one tried. There was an unfortunately worded sentence in an article I wrote for Attitude several years ago that gave the impression that you could use the two medications together. They should not be used together. You try one. If that doesn't work, you try the other. The typical dose of either one is in the range of 3 milligrams of guanfacine per day or about 0.3 of a milligram of clonidine per day. If you take all the people who get a good, robust response to either one of these medications, about 80% are going to end up at these doses. So it's by far the most common dose. There are, of course, side effects. Anything that's going to adjust the adrenaline system of the body is going to have the potential for sedation as a side effect. And this does occur for about 25% of people. It's usually mild, and it does go away over a period of several months. So a person has to be fairly patient with that. It can cause dry mouth, and it's by a different mechanism than the stimulants can cause dry mouth. So the two of them together can really make your mouth cottony dry. And the third one is an accentuation of a universal experience we've all had of when we stand up quickly and suddenly and we get dizzy, get kind of a head rush, vision goes a bit gray. The technical term for it is orthostasis, and this can happen more frequently when you take the alpha agonist medications. The benefits of the alpha agonist medications take a while to develop. When you change the dose, it takes 5 days for the benefits to develop. So once again, they're not like the stimulants where what you see is what you get at 1 hour. It takes a while for these medications to work and to see all that they can do. Just as a side note, Strattera has been looked at in 2 studies for emotional dysregulation, and the results have been what they call mixed. If they did work, it was only to a very minimal degree, almost undetectable. So Strattera does not seem to be a medication one could use and expect to have it help with emotional dysregulation. So, in summary, emotional dysregulation is a basic feature of ADHD. It is almost universal in ADHD, and it should be considered as a core symptom of ADHD that ought to be evaluated in every initial evaluation. Rejection sensitivity, it's unclear yet. This is an old concept that has only been brought up in the last couple of years. Its exact nature is still unclear. It does seem to be a specific form of emotional dysregulation, especially in regard that it does respond very well to medication. But again, how it shifts into emotional dysregulation is completely unclear at this point. It does seem to be something that's really important, though. It is a thing that resonates with a large number of people with ADHD. So at this point, I'd like to open it up to questions.
Great. Thanks, Dr. Dodson. We have many questions, but I want to invite everyone to post your questions now, and we'll tackle them as best we can. Dr. Dodson, we've been talking, and you've been helping us talk about the emotional dysregulation symptoms of ADHD for a couple of years now. And I'm wondering, to what degree do you think this is formally being recognized, and do you see any signs of the DSM being evaluated or any clear changes in the formal diagnosis that would recognize these symptoms?
If anything happens at all, it's going to take a long, long time. Rejection sensitivity doesn't lend itself to research. It's not always there. People tend to hide it, either because they don't want other people to know about that vulnerability, or it's extremely embarrassing. When it does happen, there's no way to measure it. There's no scale to measure its severity. And so that tremendously limits the ability to get research published. And so if in a publish or perish world, if your research is unlikely to get published, it's also very unlikely to get started. And so it's going to be a long time, if ever, before rejection sensitivity as a unit gets any study at all. Even people who are very interested in emotional dysregulation, such as Anthony Rothstein at the University of Pennsylvania, have very little interest in going one step further and looking at rejection sensitivity. So right now, it's very much like the concept, say, of hyperfocus. Hyperfocus is a term that most people with ADHD, it's just part of the lexicon. Coin of the realm. It's, if you talk about hyperfocus, everybody else with ADHD knows what you're talking about. But if you do a literature search on hyperfocus, there's literally nothing there. Mm-hmm. It is not mentioned in the psychiatric literature. So there are a lot of aspects about ADHD that just are completely and apparently comfortably ignored. Right.
It's really sobering, especially given how few practitioners are sophisticated about ADHD and even the basics. So it's really tough. There are a number of questions about asking sort of interesting questions about distinguishing the emotional roller coaster symptoms of ADHD from those that come with other disorders. So, for example, bipolar disorder, anxiety, and I guess a concomitant question is, can people who do not have ADHD have emotional dysregulation or rejection sensitivity dysphoria? How does one relate these symptoms from normal life and from other disorders, I guess, is the summary of the question.
As you point out, emotional dysregulation can happen to anybody under a whole host of circumstances. Get somebody drunk, and all of a sudden you're going to see disruption of their emotional life. Anything, literally anything that causes a disruption of inhibition is going to cause our nervous system not to function as well as it might. When I was talking about inhibition is how our nervous system is wired. I'll give the example of watching a 1-year-old learning how to reach over and pick up an object. They sort of hone in on it. And what they're doing is they're trying to inhibit every other motion except the one that gets them to the object they want to pick up. Now, we learn to do that so well and so smoothly that it looks very volitional. It looks like we're reaching over to pick up the pen or whatever. All you have to do is have somebody get one too many drinks in them, and all of a sudden they're back to trying to hone in and inhibit all these extra movements that come creeping in. So basically anything that's going to inhibit, that's going to affect inhibition, whether it's drugs, whether it's alcohol, whether it's bipolar, whether it's depression, whether it's especially brain injury, which is notorious for causing emotional dysregulation. Any of these things can cause emotional dysregulation. It has only been literally in the last few months, since December, that the FDA has given a go-ahead to study it specifically as it relates to ADHD. So we're right at the very beginning.
When they gave a go-ahead, how does that play itself out? What does that mean?
It means that when a drug company does a study on a new product, they can get a special FDA indication for emotional regulation.
Okay.
And that can then be converted into billions of dollars of income.
Right. So they have an incentive to.
Right. When you're looking at motivation, follow the money.
Okay. Interesting. Let's see here. Talking about some of the treatments. Well, let's go back first. There are a couple of questions from people who ask, is there such a thing as a diagnosis for RSD? Can they get diagnosed? And they're not. And many people are saying that their therapists don't recognize this term, don't understand it. Is there a literature that they can refer them to?
No, there's not. This is a symptom. Right now, it's just a symptom, highly associated with ADHD. Just as emotional dysregulation is not a diagnosis.
Got it.
And it won't be anytime soon. And what they're looking at now is emotional dysregulation as a part of ADHD.
Got it. So it's not a diagnosis. I think that's an important distinction. This is not a condition one gets diagnosed with. This is a symptom.
Right.
Yeah, I hear someone.
And it's an important one.
Right. An important one. Okay. So turning to some of the treatments, there's a specific question here about the ACT therapy, acceptance commitment therapy, other cognitive behavior therapies. What is your experience with therapies, cognitive behavior therapies, specifically for emotional dysregulation, emotional rejection sensitive dysphoria, extreme emotions?
Yeah. For my money, probably one of the best ADHD treatment facilities that I could name is one of the ADHD clinics at the Cleveland Clinic in Cleveland, Ohio. And several years ago, in sort of an evaluation, what are we doing, how well is it working, and things like that, they dropped almost everything else that they did in terms of therapies in favor of ACT therapy.
Okay.
They think that works by far the best, gets the best results. ACT therapy was originally developed for the treatment of anxiety disorders. Anxiety disorders were having the same problems that the talking therapies for ADHD were having, and that was you could show some benefit while the person was actually sitting there in the room with you, but when you came back 3 or 6 months after the therapy had occurred, there was nothing to show that it ever happened. And so ACT therapy is what's called a third generation cognitive behavioral program, primarily for anxiety disorders, but the Cleveland Clinic has modified it for the treatment of ADHD.
Is it available elsewhere? I mean, how does one find a therapist trained in ACT therapy?
I have to say I don't know exactly how one would do that. I have 2 or 3 people that are very well trained, and they're the people I refer to. But how one would find somebody just out of the blue? Yeah. Go to the internet.
Okay. Here's a question that we've heard before. We have highs and lows in emotions. Also, if you have bipolar disorder, what is the difference between the two, between the highs and lows of ADHD and the highs and lows of bipolar disorder?
The simple word is timing. When you look at bipolar, mood disorder, and ADHD, they share 14 features in common. So it is very common for well-trained clinicians to misdiagnose ADHD as being bipolar, or to miss that you're dealing with both of them. 2 huge studies, the STAR program and the STEP BD program, both of them found that there's a tremendous overlap. If you have bipolar disorder, you have a 40% chance of having ADHD as well. So the question is it one, is it the other, or is it both? You separate the two, when it's one or the other, because mood disorders, of which bipolar is a classic mood disorder, have a life of their own, separate from the events of the person's life, outside of their conscious will and control. The moods are pretty much doing whatever they please, and the person, there's nothing that triggered them. They just come and they stay. Usually the onset is very gradual over a period of weeks to months. By definition, the mood has to be continuously there for at least 2 weeks, and then its offset or resolution also is gradual over a period of weeks to months. With ADHD, you see a very different, totally different pattern. There, the moods are clearly triggered. A person with ADHD, maybe some observer can't tell how they were triggered or what triggered them, but the person with ADHD can clearly say, when my mood shifts, I can always see a trigger. My mood matches my perception of the trigger. The technical term is the moods are congruent. It's a technical term. The mood changes are instantaneous. In other words, they are the same as everybody else's mood in every way except their intensity. People with ADHD, the mood switches are extremely intense, much more so than a neurotypical person. It is very rare that the moods of ADHD stick around more than a few minutes to a few hours. It is extremely rare for them to last 2 weeks. And usually the mood can be removed by the person with ADHD finding a new interest or occupation that captures their involvement. So usually those are the things I use to separate out mood disorders of all types from ADHD.
Yeah, that makes sense. There are parents listening in who are wondering how to cope with a child with ADHD who has sort of a meltdown, or how to discipline or deal with a behavior without triggering a sort of rejection, sensitive dysphoria episode. They're sort of struggling with how to react to an emotional or volatile even child's behavior.
At the moment, there's absolutely nothing you can do. It's got to run its course, usually. The first thing as a psychiatrist I would evaluate is whether or not these temper tantrums are indeed temper tantrums. Do they have a secondary gain? Are they manipulative? Is it done to get their way? As soon as they get their way, does the temper tantrum go away? Once it's achieved its goal? Somebody with ADHD, when they have one of these meltdowns, they may get what the trigger was or something like that, but usually this goes on much longer. A person with bipolar, especially children with bipolar, can also have what they call affective storms. If you've ever seen one, you'll never forget it. These are way, way, way beyond temper tantrums. So again, it's a matter of degree. So if I were fairly sure that this was not manipulative, just so that the kid can get his way on pretty much any conflict with the parent, first thing I would do is hope that I could, they're in that lucky 60% of people who respond to medication. If they're in the 40% that doesn't respond, then I would do what I could, which would largely be behavior management, trying to give these people some sorts of ways to correct their distortion that what was said actually was a put down, a rejection, a criticism, etc. Which, as you can imagine, somebody who's deeply wounded by that sort of thing is going to be vigilant for it. Okay. And they can see it when it doesn't exist.
Okay, interesting. Question from several people about the distinction between borderline personality disorder and emotional dysregulation. There are several people listening in who say they have been diagnosed with borderline personality disorder. They're not sure whether that was a mistaken diagnosis and one that's, and is it often confused with emotional dysregulation?
It is very often confused with emotional dysregulation. The whole discussion of what bipolar personality disorder is and isn't would fill another hour rather completely. Right. The fundamental of it is that at its heart, bipolar is a disorder of relations with other people, or they call object relations, in which initially the person over-idealizes other people, gloms onto them, wants to be around them all the time, is emotionally very dependent on them, until they feel as if they're losing themselves in such a person, or they get discouragement or rejection or something like that, and then they quite literally fall to pieces, and can then demonize the person, attack them. How could I have ever had positive feelings for you? It's a complete and total swing from over-idealization to complete denigration in the twinkling of an eye. The term borderline comes from the original thinking about it, that these were people who occupied a very thin line between very severe neurosis and psychosis, and that under stress, under rejection, and that sort of thing, they would go below the border and become frankly psychotic. So these, again, are more than just disappointments. This is a psychotic level of disorganization, but it comes out of that relationship, that over-idealized relationship with another person. If that is not what these people experience, if it's just that they get overwhelmed by their own emotional experiences that are normal emotional responses to the events of life, then you start thinking more in terms of ADHD.
Okay. Interesting. A couple of questions about the life cycle, I guess I would call it. There's some people who say they were much more emotionally sensitive as they were younger, and they feel that they've learned to cope with their emotional swings as they've gotten older. Another questions relate to a menopause and or the use of hormones to manage the emotional symptoms of menopause. Do you see any connection between sort of hormone changes in older years and people's symptoms change over time? Their emotional dysregulation or rejection-sensitive dysphoria symptoms?
Not specifically. What estrogen has a profound effect upon emotional regulation, whether you have ADHD or not. All you have to talk through is a young woman who was put on the wrong birth control pill, and the hell that they go through for the next month in terms of being totally dysregulated in terms of their emotional lives. Just a little bit of estrogen, of the wrong estrogen, or even the wrong brand of a particular pill can make a huge difference in emotional regulation. So estrogen is particularly potent. On top of that, women with ADHD seem to have PMS is the old term for it. The current term is premenstrual dysphoric disorder. They have it much more frequently, much more severely than the general population. And basically what the trigger for menses is that the level of estrogen suddenly goes to zero. And the lining of the uterus is sloughed. And a lot of women have very strong emotional shifts in that 1 week before their menstrual period begins. Menopause is nothing more than a permanent loss of estrogen in the mid to late 40s. and a lot of women with ADHD who've been taking ADHD medications for their lifetime suddenly report that suddenly, with menopause, their ADHD stimulant medications in particular don't seem to work. They raise the dose, they switch them, it just doesn't seem to work until they get some form of hormone replacement therapy, and then the stimulants seem to kick back in. There is extremely little literature on this.
Mm-hmm. Yeah.
Just as there's extremely little good and reliable research on women's hormones to begin with.
Okay. There's a new diagnosis called DMDD, disruptive mood dysregulation disorder. Could you speak a little bit about what that is and how it relates to the emotional dysregulation side of ADHD?
That is a diagnosis that nobody likes.
DMDD.
Yeah. It was an attempt to find something that everybody could go along with in the concept of childhood onset bipolar. The Europeans in particular do not like the term of childhood onset bipolar disorder. And so this was something they came up with, and the people in the United States don't like it. It's very vague, very nonspecific, very hard to do good research on it. So in an attempt to find a compromise, the people who write the diagnostic and statistical manual make sure that everybody was unhappy. So that's basically what it is.
So in your view, Dr. Dodson, though, is there childhood bipolar disorder then?
Yes, absolutely.
Yes. Yeah. And there are several mentions here in this webinar, but we also hear this frequently at Attitude, parents who say their children are violent and violently angry. And are in those cases, is it possible that this is not ADHD that's at play?
Yes.
Yeah.
I take that back. Joe Biederman and I can't remember her name. It'll come in. Wozniak. Not Wozniak. I can't remember her name. Published a very good article showing that there's a 97% overlap between the children that they ended up diagnosing as childhood onset bipolar and ADHD, that most people ended up having both.
Oh,
there was also a 97% overlap between childhood onset bipolar and oppositional defiant disorder. These are extremely difficult children to manage or to live with.
Right. Right.
So it's not one or the other. It's usually both. One of the questions that again, it's not a formal question, but one of the questions I ask parents are you scared of your child? Mm-hmm. Do you sleep with your bedroom door locked? A lot of parents who have a bipolar child will be very shy and embarrassed to say so, but yes, they sleep behind a locked door.
Right. Yeah, when I would say see one or two questions along those lines in almost every webinar, and it's clearly a very different level of behavior than most of the ADHD parents who are adults that we encounter. So, yeah.
That's the affective storm that I mentioned earlier. It's something you'll never forget.
Right. So let's see, a number of questions. Here's an interesting one. There's a number of questions about treatment with stimulants and alpha agonists, but here's someone who wants to know, have you seen in your extensive clinical practice adults with ADHD able to manage well in life without medication therapy?
Of course they do.
Interesting.
Yeah. People with ADHD are much brighter than the general population. They are world-class problem solvers. They are clever people to the extreme, and they find ways to manage their ADHD. In 2014, the average age of diagnosis of ADHD in the United States was 31. We can't really consider this a childhood diagnosis anymore when more than half of people are being diagnosed after their 31st birthday. More adults are being treated now than children. So what happens is most people with ADHD find ways to cope with their ADHD. They're willing to work twice as hard for half as much. They struggle through life. Many of them can be quite accomplished, but they do so at a great personal cost.
Right. So the answer is yes, they can survive and do well without medication. Right.
Yeah. I'm not sure why they would want to, but they do.
There's a great question here, which I read out only because I think it illustrates your talk so well. It says, my now 15-year-old son has always responded to any suggestion, such as, say, take a shower, with shouts of, "You're insulting me." This sounds like the definition of emotional dysregulation, or no, rejection-sensitive dysphoria. Is that?
Yeah.
Yeah. Interesting.
Here it is put down as an accusation rather than this is what people do. Right. Everybody does.
Yeah. And the next question is, so how do I talk to my son without sending him into this angry defense?
The way I would do it is put it back to him. Look, this, bathing is something that people do. Everybody does it. It's part of our culture. How can I ask you that question without you overreacting to it? How can I ask you? You tell me how I or anybody could ask that question without you taking offense. The problem is not with you as a parent. You have to put the problem back with the adolescent.
Interesting. Let's see here. There's a number of thank yous here. Thank you for holding the centers. You've changed my life. There have been Dr. Dodson. There are a number of people here for whom, how does Dr. Dodson understand us so well? I remember those kinds of comments that I think I wanted to relate to you.
Thank you. Thank you very much.
Let's see. Trauma. Oh wait, this is someone, I just have to read this. This is me, exclamation point. This is me, exclamation point. So one more comment of someone who feels understood. Thank you. Trauma. There are a number of people who experience trauma themselves in their childhood or who have children who experience trauma, and they're wondering how to distinguish those symptoms from ADHD symptoms.
It's very difficult. There was a paper many, many years ago by a guy at Harvard that estimated that by the 12th birthday, the average ADHD child heard 20,000 additional negative or corrective messages. I'm sorry, but 20,000 additional corrections cannot help but have a huge impact on anybody's development, on anybody's development of who they are, what they're worth, what's valued, etc. Growing up with untreated ADHD requires everything. It affects everything. So, trauma is going to be there, I think, in just about everybody. It's a tough way to grow up.
Right.
I think it is a false distinction to say, is it one or the other? Is it trauma or is it rejection sensitivity? I think they feed on each other. I think one makes the other worse. Right.
Okay. Well, I think we're out of time. I want to thank you so much, Dr. Dodson. You've made a huge difference in the lives of so many people, and we are honored to have you at Attitude and to work with you. So thank you, everyone. Thank you, everyone, for listening. For those of you who would like to listen to this again or to share this with your family or practitioners, you'll find the replay on the Attitude website later today, attitudemag.com/webinars. And we hope you'll come back and listen to our webinars soon. Thank you, Dr. Dodson. Bye,
Thank
everyone.
you. Thank you for inviting me.
Bye.
For more Attitude podcast and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com. That's ADDITUDEmag.com. That's ADDITUDEmag.com.